and it's my honor to introduce the first session in our first day of the conference, entitled with the Paradigm Management of Urothelial Cancers. And I'm honored to welcome our distinguished, prestigious chairman, Professor Ahmed Hamada, chairman of Clinical Oncology Department, Qasr Al Aini, professor of Clinical Oncology, Professor Tariq Hussein, professor of Clinical Oncology at Shams University, and Professor Hisham Al-Wakil, professor of Clinical Oncology at Shams University. The screen now is yours, our dearest chairman.
دكتور عماد اتفضل يا فندم.
بسم الله الرحمن الرحيم. Good evening, everybody. I would like first to congratulate the Clinical Oncology Department in Shams University for their 7th annual international conference. And really, I hope that because it is the first one which is becoming virtual, so I hope that we will learn a lot from this scientific meeting, especially that you have a very great panel of experts and speakers. So thank you very much for all the team, and hoping that we will have definitely a fruitful meeting.
Dr. Ahmed, appreciate introducing Professor Scott North.
I didn't have the agenda. I don't have the agenda of the meeting. So if you can introduce the first speaker.
Dr. Nermeen, please introduce Dr. Scott North, please.
Yes, sure, it's my honor. Okay. Welcome. Welcome, Professor Scott North. Thank you so much. We are honored by your presence today. One of the eminent international figures in the GU malignancies. And we will enjoy now the topic of management of advanced renal cell carcinoma, integrating vascular endothelial growth factor receptor targeting and immunotherapy for optimal outcome.
Thank you very much. Very pleased to be here with you virtually today. I'm sad that I can't be with you in person and see your lovely country, but I hope to do that at one point in the future. I will share my screen now, and hopefully you can see my slides. This is the first presentation that I was asked to provide, which will be advanced renal cell carcinoma and integrating our VEGF targeted therapies with immunotherapy to improve outcomes for patients. I'll just control here. My objectives will be to review, first of all, some global outcome data looking at the changes in kidney cancer patient outcomes since we've had tyrosine kinase inhibitors and immunotherapy, discussing a little bit about our first-line management of metastatic renal cell carcinoma based upon the IMDC score, which is important for risk stratification. And then I'll look at second-line data, and I will share with you one of our national algorithms that we have developed here in Canada, which helps us to potentially select patients and develop a sequencing strategy. And then I'll share with you one of my patients who is doing quite well with therapy. These are my disclosures. So I want to just take a step back, first of all, and remind everybody about how far we've come with the management of kidney cancer in the last 20 years. When I first started practicing in the year 2000, all we had available was interferon and interleukin-2. And when you looked at the outcomes of patients treated in the cytokine era, which was originally published by Motzer from the Memorial Sloan Kettering experience back in 1999, one would see that a favorable risk patient had a median survival of about 20 months, an intermediate patient about 10 months, and a poor risk patient only 4 months. And since the majority of patients were intermediate risk, we used to say on average when a patient with metastatic kidney cancer came for a consult, that they had about a 1-year median life expectancy. So very poor outcomes. And then we go forward in time to when we're now using tyrosine kinase inhibitors, and my colleague Danny Heng, who works at the University of Calgary, when he was a fellow, developed the IMDC project, the International Metastatic Database Consortium. And that particular project started off with validating new prognostic factors in the TKI era. And what he was able to demonstrate by having 6 clinical and laboratory factors is that a patient could be stratified once again into good, intermediate, or poor risk. And now our good risk patients are living about 43 months, the intermediate 22, and the poor risk are 8. So in the last 20 years, we have doubled the life expectancy of patients with metastatic kidney cancer. And I think that's something that we should all be proud of as the treating and research community, because that really has made a big difference in the lives of our patients. But now where are we and what is developing? Right now, we have new developments in immunotherapy, both in terms of doublet immunotherapy as a first-line treatment, but also combining the immunotherapy with the targeted therapy of the vascular endothelial growth factor receptors and looking at IO plus TKI combinations. And I will review some of these high-level trials just very briefly. And then in the second-line setting, we've made significant improvements as well. And what we have to remember is that all of our second-line treatments will be very different now compared to what they were even 4 or 5 years ago, because everything changes based upon what we do in the first-line setting. But we do have immunotherapy data as well as TKI data, and I'll share that with you. So first of all, I would like to just remind everybody about the Checkmate 214 trial. This was the ipilimumab plus nivolumab first-line study, which compared the doublet immunotherapy to conventional sunitinib. And it's a study which many of us will be very well familiar with, where the patients enrolled were all treatment naive with a clear cell component, and they were stratified by their IMDC score so that we had an even balance between the arms between the favorable, intermediate, or poor risk. And then were randomized to receive either ipi-nivo or the conventional sunitinib on the 4-week on, 2-week off dosing schedule. The ipilimumab was for 4 doses maximum in combination with nivolumab, and then the nivolumab was continued as a maintenance therapy until progression or toxicity. And this trial has been presented multiple times, and there was an update at the GU symposium in February, as well as some recent updates at ESMO. And what we've seen is that this is one of our best studies now in the first-line setting with immunotherapy that has mature data. This particular analysis that was done at ESMO has 42-month follow-up data. And what it's telling us now is that we can see around a 10 to 12% improvement in overall survival at any given point in time when you compare to sunitinib. And in fact, now with further follow-up around 48 months, we have a median overall survival in the ipi-nivo arm of about 4 years. So as I mentioned just a moment ago, we were impressed that we doubled the survival with TKIs out to 2 years. Now we've doubled it again with immunotherapy out to 4 years. And what's impressive is that I think we've all seen these patients on the tail of the curve who seem to have a complete response and they don't progress. And I'm afraid to say it, but I think they might be cured. And we certainly have seen these patients who do well for a very long time. Overall survival, similarly, we have an improvement, but it's albeit very small in the favorable risk patients, which would imply that in the good risk patient population by the IMDC criteria, ipi-nivo really isn't necessarily the best choice for these patients. And that patient group, when you look at biomarkers and how they respond, they really do seem to get the benefit from the tyrosine kinase inhibitor, and the oral agent is still quite important. So that leads you to the alternate strategy of combining an immunotherapy agent with a tyrosine kinase inhibitor. And the doublet IO strategy was certainly favorable with Checkmate 214. And in the Keynote 426, we were taking advantage of using pembrolizumab with an active TKI like axitinib. The Keynote 426 study is demonstrated here. Once again, this is a treatment-naive first-line study where patients were stratified by their IMDC group, and then they were randomized into 2 groups, one being the conventional sunitinib and the other being the axitinib with the pembrolizumab. And the axitinib dose could be titrated up or down. It started at 5 milligrams twice a day, but then it was titrated up if the patient tolerated it, although many patients did not actually titrate above 5 milligrams twice daily. And the pembrolizumab was a fixed dose for a maximum of 2 years of therapy. The overall survival for the entire population demonstrated again at a 2-year landmark analysis about an 8% improvement in overall survival. And we just have to remember that this data is less mature than the ipi-nivo data, which is why many people would still be more in favor of ipi-nivo in an intermediate or poor risk patient population because that data is more mature. And if one breaks this down a little bit in terms of the risk groups, overall survival, you see significantly improved survival in that intermediate poor risk patient population, as well as a much better response rate, including an 8% complete response with the combination therapy. And a theme that comes out of all of these immunotherapy trials is that as you follow over the course of time, you actually see the complete response rate go up. So these responses take a bit of time to mature, which is why the length of follow-up on these trials is actually important, and we don't want to do cross-trial comparisons of results, especially when the trials are at varying points of their maturity. In the favorable risk patient population, the initial reports of this data had a better benefit for the immunotherapy TKI combination than what was seen at the longer follow-up. But nonetheless, if I go forward one slide to the forest plot of subgroups, there doesn't appear to be a subgroup which doesn't necessarily benefit. One of the key points about the survival and the inability to make a lot of conclusions is that when you have a small number of events, only 17 death events in the favorable risk population, your confidence intervals on any type of statistical analysis are very wide, and it's difficult to make any type of distinct conclusion. As such, we do need to make sure that when we look at these types of subgroup analyses, we remember that they're really there to flag us to any major concerns that we would have with not treating a patient population, and they are hypothesis generating, not for definitive conclusion. So overall, this is still a study that is positive and across all subgroups of patients. For the sake of completeness, I'll mention the Cabo-Sun clinical trial. This was a first-line cabozantinib versus sunitinib study. It was a randomized phase 2 trial with a primary endpoint of progression-free survival. And as such, in the current era where we have large phase 3 studies with an overall survival benefit, it really doesn't necessarily support cabozantinib as a first-line therapy as a monotherapy. But what we've heard about recently at ESMO is this new data, which I'll mention in a moment, combining cabozantinib with nivolumab as a first-line treatment, which is quite exciting. Before I do the stuff in progress, I just want to quickly review the second-line data that we have, which is mature. The final analysis of the Checkmate 025 study was presented this past ASU-ICOC in February. And this was our pivotal second-line randomized trial of monotherapy nivo compared to everolimus in a pre-treated patient population. Just to remind everyone about the trial criteria, this was a patient population that was pre-treated. Most of these patients had had 1, if not 2 lines of anti-angiogenic therapy, and the patients were then randomized between monotherapy nivolumab at the 2-weekly dosing interval or the conventional everolimus, which was the standard of care at the time based upon the Record 1 trial. The overall survival is depicted here. The median difference is about 6 months in overall survival, but once again, when this trial first published, it was quite impressive that in a second line and beyond setting, we were still achieving median overall survivals of a couple of years, which if you think back to 20 years ago, we couldn't even achieve that with first-line therapy. And this was certainly further evidence that the immunotherapy was the best choice for most patients in a second line and beyond setting. Now, right around the same time that all the data was emerging for nivolumab, we were seeing data emerge for cabozantinib in the second line setting, and the METEOR clinical trial presented by Tony Schwery was the pivotal study that established cabozantinib as an option in the second line and beyond of therapy, due to its unique characteristics of targeting, including the MET inhibition, And it was an attractive study, again, comparing to everolimus in patients with clear cell RCC progressing on prior TKI therapy. The dose of cabozantinib of 60 milligrams a day was difficult for most patients to stay on, and most individuals actually had to be dose reduced. And the median dose obtained was actually only about 45 milligrams per day when you average it out across all the patients. So the 40 milligram dosing seems to be far more tolerable for patients than does the 60. Nonetheless, this was a study, once again, which was positive in beating everolimus as far as a second-line therapy, with, again, a survival that was approaching 2-year median overall survival in second line and beyond. This is not to say that we could use these data to compare nivolumab to cabozantinib. They are both very active drugs. And one of the comments about the METEOR trial is that this particular study did have a subgroup of patients within it, very small, that had previously been exposed to immunotherapy. Most of them had had interferon or interleukin-2, but there was a small subset that had previously been exposed to a PD-1 or a PD-L1, which means that cabozantinib is one of the few agents with randomized data showing some benefit in a post-IO treated patient population. And that becomes an important consideration when we think of sequencing. And in my country, where we have to go through a national funding process and show levels of evidence and data to support a funding request, it supports the concept that cabozantinib would be a preferred drug in a post-IO setting. And for the sake of completeness, I just would like to show a couple of screenshots from some of the other trial data that supported second line and beyond. And we've heard about the lenvatinib and everolimus combination, which was also trialed against monotherapy of either agent in a patient population progressing on a prior targeted therapy, treatment until disease progression, and an overall survival and progression-free survival that was significantly improved. Here's the PFS Kaplan-Meier plot, demonstrating basically a doubling of the response rate for the combination compared to lenvatinib, and a tripling compared to monotherapy everolimus. And I think it's fair to say that monotherapy everolimus has fallen out of favor in most parts of the world if access to other drugs is possible. The overall survival updated analysis is presented here. And once again, you see a similar overall survival of approximately 2 years for the median for individuals receiving the combination. This combination is being further examined in a first-line randomized study, which I'll mention momentarily. Consequently, what is on the horizon? What is it that we should be looking for in terms of data? When I first put these slides together, we didn't have the data on the Checkmate 9ER study, but I will show you a couple of slides in a moment. But nonetheless, it was an impressive press release stating that the combination of nivolumab plus cabozantinib versus sunitinib was positive both for all of it, overall survival and progression-free survival. And that was as the result of a positive press release initially. The data is now presented as of ESMO just a few days ago. We are waiting as well for the CLEAR first-line clinical trial, which is a trial combining lenvatinib with IO, again, leveraging the information that we've learned from the Keynote 426 study of the benefit of a TKI with pembrolizumab. So lenvatinib will be compared to, with pembrolizumab will be compared to Len-Eve with a control arm of sunitinib. And I think one of the important things to remember is that all of these clinical trials that compare to sunitinib do compare it to the conventional dosing as per the product monograph, which is the 4-week on, 2-week off regimen. But in clinical practice, it's very common, at least here in Canada, to do dose individualization of the sunitinib and adjust the dosing and the schedule to optimize results. And we've got some Canadian data as well as data that's been generated by MD Anderson that supports that being less rigid with the 4-2 schedule of sunitinib may improve your outcome. But whenever these clinical trials are done, they must be conducted with that conventional schedule because that's how the product monograph is written. And then finally, there are a number of new compounds in testing, and I think some of the more exciting ones might be the HIF-2 alpha antibodies, which will be a brand new class of agent where we could explore their activity in a prior TKI and IO pre-treated population. This is the data from the CheckMate 9ER study, which is initially the PFS data, and you can see a doubling of progression-free survival with sunitinib nivo-cabo compared to sunitinib. We're now seeing that this progression-free survival is about 16.5 months. The sunitinib PFS of 8.3 months is on the lower side. The pivotal sunitinib versus interferon study was about 11 months, but it's certainly in the range of what most of the control arms of clinical trials with sunitinib have demonstrated. So this is not a study which is positive because of a gross underperformance of sunitinib. It is actually positive because of the improvement that we see with combination therapy. Now, for the overall survival, this is very immature data. And as such, we don't have median overall survival for either arm, but we do know from statistical modeling that the hazard ratio is 0.6, which is quite an impressive hazard ratio for survival, and that this would be statistically significant in favor of the combination. How this will play itself out in terms of choices in the future will be interesting, simply because if an individual has received immunotherapy and the only TKI that is beneficial after immunotherapy, it does lead to some interesting questions about what type of data we have to support second-line therapy and beyond when a patient progresses on nivo plus cabozantinib. But that is something that will have to be worked out either through ongoing clinical trials or, most importantly, many jurisdictions, including ours, can generate some real-world data which might help to inform clinical decision-making. So as a proposed algorithm, in Canada, we have a Kidney Cancer Research Network, which meets once a year to put together guideline development and updates, as well as to promote research in the country. And the guideline development is supported by medical oncologists, uro-oncologists, and as well we have radiation oncologists where RO is required for input. What we've done is broken down our algorithm by first-line therapy and then second-line and beyond. And we've determined that your treatment will be predicated on what you've received before. In the first-line setting, if you are a favorable risk patient as per the IMDC criteria, based upon CheckMate 426, the preferred treatment strategy would be the combination of axitinib and pembrolizumab. We did not make a change in the recommendation with further updates to the Keynote 426, and we still feel that the axitinib and pembrolizumab combination would be the best treatment for this patient population. There may be individuals who are unable to receive immunotherapy because of absolute or relative contraindication, and if they cannot receive IO, then we would recommend that they receive a TKI because those patients do not seem to benefit from doublet immunotherapy. So sunitinib or pazopanib would be reasonable. They've got randomized phase 3 trials with an overall survival endpoint. Cabozantinib was not given as strong of a rating simply because it's a phase 2 study with a PFS endpoint, therefore would not be as high of a quality level of evidence. If a patient is intermediate or poor risk, then based upon the ipi-nivo data, we would recommend that ipi-nivo be the preferred option because of the maturity of the data, the very significant survival signal as compared to the sunitinib arm, and overall in the hands of cancer centers and treating physicians who can work with ipi-nivo and have experience, it's well tolerated and safe. But if a patient can't have doublet IO, or if a clinician or patient is a little bit fearful of the potential complications of the addition of the CTLA-4 antibody with ipi, then axitinib and pembrolizumab is certainly an option based upon the Keynote data as well. And similarly, for patients that are unable to receive IO, monotherapy TKI would be preferred over other agents, but this is falling less and less into favor as most people, unless there's an absolute ongoing active autoimmune disease, could tolerate an immunotherapy treatment. In second line and beyond, we have to think back now to what our patient has previously received. If an individual has only received monotherapy TKI, this could be a patient who's been on treatment for many years already who subsequently progresses, as opposed to a new start, because most patients are getting combination therapy as a starting point today. But if a patient of mine is progressing on sunitinib or pazopanib, If there is no contraindication to immunotherapy, then nivolumab becomes our next best option. And then following nivolumab, we will generally go to cabozantinib. But if a patient has an immunotherapy contraindication, then we will usually look at axitinib or cabozantinib. And we are often, from a very practical perspective, trying to ensure that we maximize the numbers of lines of therapy. We don't want a patient to really have less than 3 funded lines of therapy, because in Canada, everything is done through public insurance and nobody has private insurance, generally speaking. So we need to make sure that we have all of the access through the government-funded system. If a patient is post-immunotherapy alone, this could be the circumstance, for example, of ipi/nivo followed by progression. Then we would look at TKI therapy as the next line of treatment. And we were able to advocate for sunitinib in this particular patient population, even though we know there's no randomized phase 3 data, but there is randomized phase 2 data for sunitinib in the post-interferon and IL-2 patient population. And then following that, we have cabozantinib as a third line. So our usual strategy is ipi/nivo, followed by sunitinib, and then followed by cabozantinib. And for those individuals who are starting off on combination therapy, such as axitinib plus pembrolizumab, then second-line therapy will usually consist of cabozantinib. We do not have a funded third-line therapy in Canada for that patient population, which does result in a little bit of a worry for the clinicians. Some patients may have the opportunity to get access to everolimus through some drug plan that they may have. And currently in Canada, we can get compassionate lenvatinib, so it would allow you to create a regimen with some compassionate drug as well as some patient to pay. But to be fair, the data for lenvatinib plus everolimus in a third-line setting after axitinib, pembro plus cabozantinib is basically zero. So clinical trials and supportive care are certainly reasonable options. So what do I do most commonly in day-to-day practice? I usually start my good risk patients off with axitinib and pembrolizumab. Then upon progression, they go to cabozantinib. And of course, if they progress beyond that and their performance status is adequate, then we will try clinical trial. And I think it's fair to say that if we have clinical trials at any point along the way, we would encourage patients to participate in trials, because that's how we can improve our knowledge base. For the intermediate and poor risk patient population, we'll start them off on ipi/nivo unless there's a reason we are concerned they cannot tolerate the doublet IO therapy. And then upon progression, it is a therapy with a TKI, most likely sunitinib, and then following that, third line cabozantinib. So to finish, I'll share with you a patient case of mine who I'm currently managing. This is a man who is right now 59 years of age. And 13 years ago, when he was quite young, in his 40s, he had a left radical nephrectomy. He had a T2NX lesion that was resected at that point. It was a pure clear cell RCC with a grade 3 Furman grade noted on pathology. He underwent follow-up through urology, and after 5 years of follow-up, he was discharged from urologic follow-up and was followed by his primary care physician. In January of this year, he was having a routine chest x-ray, and it was noted that there was a pulmonary nodule. So he subsequently had a CT performed, and it demonstrated multifocal metastatic lung disease, mediastinal lymphadenopathy of around 1 centimeter. And interestingly, he had intramuscular metastases, notably in his trapezius muscle and in his gluteus. And he was originally worked up in the community by a sarcoma physician, thinking that perhaps this was a rhabdomyosarcoma or some other sort of soft tissue sarcoma. But the pathology on biopsy was a recurrent renal cell carcinoma 13 years after the original nephrectomy. These are just a couple of screenshots to show you this large trapezius muscle metastasis, which was heterogeneous in its contrast uptake. This was a bit painful for the patient, and so he actually did have some palliative radiotherapy to this lesion. He did not require radiotherapy to his gluteal lesion, and this is just a sample of one of his larger pulmonary nodules on CT. His performance status is ASU-ICOC 0, and all of his blood work is normal, and he is more than 1 year from his initial diagnosis to the need for therapy, and as such, his IMDC score is 0, which means he's a good risk patient. So we decided to start him on axitinib with pembrolizumab. And as I mentioned, he did have some radiotherapy to the trapezius metastasis. The axitinib was started at 5 BID, the pembrolizumab fixed dose, 200 milligram Q3 weeks, and that started in February of this year. And in fact, he tolerated this so well that he kept calling, asking when the side effects were going to start, and he was concerned that he was being underdosed because he was not having any major toxicity. After 12 weeks, we repeated his imaging. This pulmonary metastatic lesion is becoming a bit smaller and a bit less distinct. Interestingly, there was no change in the mediastinal lymphadenopathy. The trapezius metastasis is improving in terms of its vascularity and its size, but I would caution us not to read too much into that because it was radiated. Now, in June of this year, after 4 months of therapy, he actually developed hepatotoxicity, and both pembro and axitinib can cause hepatotoxicity, which may result in a difficulty in figuring out which drug is causing the problem. Now, generally speaking, unless it's a high-grade transaminitis, what I'll simply do is hold the axitinib because the half-life is so short that if it's the axitinib, it'll get better very quickly, and I don't immediately embark on steroids unless there are other concerns with regards to either an elevated bilirubin or other evidence of immunotherapy-related toxicity. With holding the axitinib, the LFT is normalized. I restarted him at 3 milligrams twice a day, but once again, his transaminases went up, so it was held, and now he's on 2 milligrams twice a day without problem, and I never did hold the pembro. 6 months on, his pulmonary lesion continues to get smaller. All of his lesions are shrinking, with the exception that the mediastinal nodes are a little bit larger. And our radiologist is actually questioning if this is malignant and could it be something else such as sarcoidosis. His muscle metastatic lesions are almost completely gone. The patient has no pain and he cannot palpate the lesions any further. The plan would be for me to continue on with therapy, and if the mediastinal nodes continue to get larger, we'll actually send for mediastinoscopy to see if there are two processes going on, because it would be unusual to have progressive adenopathy while everything else is shrinking. So I will continue on with this treatment until he maximizes the benefit from the pembrolizumab at 2 years, at which point we must stop. And then ultimately in the future, should there not be any changes in therapy or clinical trials, I will use cabozantinib for him when he progresses. So in conclusion, I think it's important for us to remember to put the IMDC score onto all of the patients that we see with newly diagnosed renal cell carcinoma, so that we know what category they're in, and that will inform our decision-making for therapy. The good risk patients will benefit from axitinib and pembrolizumab, followed by cabozantinib. Now the question will be, if we use nivo plus cabo in the first line setting, what will we do thereafter? And I think that is an open question. The intermediate and poor risk patients benefit from the combination of doublet IO up front, followed by TKI therapy. And I just would like to remind ourselves once again of the tremendous improvements that we've made. Sometimes we don't see it because the progress is slow and we have to look back over the course of time to see what we've done. But we've actually now effectively taken median overall survival for all comers in that intermediate range from 1 year to 4 years with ipi-nivo. And that's something that we should all be very proud of. So with that, I'll stop, and I would gladly take any questions that you may have.
So thank you, Professor Scott, for this elegant presentation. And if you have any questions.
الو دكتور عماد. هاي دكتور عماد.
ايوه. Do you have any questions, please?
I'd like to ask a question to Professor Scott.
Please.
Can you hear me?
Yes, I can.
Yes. Hello. How are you? We're so honored to have you today with us, Professor Scott.
Thank you.
I'd like to ask, I noticed that you stressed on the use of axitinib and pembro for good risk patients, but it's also beneficial to be used with intermediate and poor risk. why don't you prefer to, or is it per guidelines, Canadian guidelines, or why is it your preference that you put it, you didn't put it for all comers, axitinib and pembro?
Yeah, absolutely. I think it's a very fair question. And the only reason why we have debated this in our country about the use of axitinib and pembro for good risk and ipi/nivo for intermediate poor is simply related to the fact that we do see with ipi/nivo a longer follow-up, a bigger tail to the curve, and a slightly higher complete response rate. And I think the only issue that we have is just the maturity of the data. I have used axitinib and pembrolizumab for the intermediate risk patient if I was concerned, for example, that I didn't want to use the ipilimumab, because that is really the drug that gets us into difficulty with toxicity. And we debated this on a national basis about whether we would stress ipi/nivo over axi-pembro for the intermediate poor. And about the only reason why we would look to be ipi/nivo in a patient that could tolerate it is the longer follow-up, the more maturity of the data, and the more stability of those PFS and OS curves. We do know that the maturity of the axi-pembro data is less. Those curves can shift with a little bit over time. So there's absolutely nothing wrong with axitinib and pembrolizumab whatsoever. It's just strictly a function of the maturity of the data. And I have patients on both. And I've certainly chosen the axi-pembro, especially in somebody who was a little bit older or a little bit frailer. And I was concerned about the toxicity of ipi/nivo because pembro is so well tolerated. And if you get into a problem with axitinib, when you stop it, it goes away so quickly. So your question is absolutely correct. There's not necessarily something to choose between the two. It's just strictly an issue of the maturity of the data.
So just because of the longer follow-up with checkmate, so that's why, yeah. Okay.
Correct. Yeah.
Thank you, sir.
As we get further updates with axitinib and pembro, and that data is more mature, and we have ongoing confidence,
yes, exactly.
We'll be able to have more confidence. The only thing with axi-pembro, we saw a shift with that good risk patient population that the benefit was lessened, and we saw less benefit even with the hazard ratios for the intermediate poor over time. I think we just want to make sure that with the next follow-up that it's actually consistent.
Thank you so much. Thank you, sir.
Professor Scott, can I have a question about the cabo and its toxicity? Because definitely we don't have cabo till now in Egypt, but I think we have learned that cabo have a little bit toxicity even in the prostate cancer management. What about the toxicity of cabo, especially if a patient will take him as a second-line treatment?
Yeah, it's an excellent question. I believe that the 60 milligram dosing is the problem. When we did the METEOR study, when I had a couple of patients here on METEOR, we could not manage them on 60. Significant GI toxicity, a lot of diarrhea, a lot of problems with mucocutaneous toxicity, including fistula, a perirectal fistula, which was a real problem, especially when you have diarrhea. And I think in that second line and beyond setting, those patients were more ill and they didn't have a lot of reserve. When you reduce the dose to 40, they seem to tolerate it much, much better. And the toxicity data from the Nivo-Cabo trial, the Checkmate 9ER, where the trial dose was 40 milligrams, was far better tolerated than the toxicity on METEOR. So I personally, when I start cabozantinib, I will start the patients on 40 milligrams a day. And after about 8 weeks, I do their scan. And if they're responding, I don't push the dose because there's really no point in pushing the dose if the patient is already responding. If the patient is not responding and you want to see if they tolerate 60 milligrams and push the dose a bit before you give up on the drug, that would be the time to do it, because you can justify the possible side effects because the patient's not benefiting. But it is a more toxic drug than the other TKIs. I think like any of these drugs, the more experience we get with them, the more we understand how to work with them. And we'll even dose individualize a little bit so that rather than giving it every day, we may give some people a couple of days off if they're having toxicity and play around with the schedule. But I can't formally endorse that because that would be an off-label use of the drug, but that would be practically what we would do is give them a bit of a break.
Thank you. Any other questions, please? So we can move to the second session, second topic about the management of castrate-sensitive prostate cancer and the treatment sequence by Professor Scott, please.
Right. Are you able to see my screen with?
Yes.
Yes,
Perfect.
clear.
Yes. Yes.
So my second talk with you today is going to be advanced prostate cancer and some of the advances in the management of metastatic castrate-sensitive disease and some options for sequencing. And I was also asked if I could possibly mention a little bit about the non-metastatic CRPC space, and I will do that as well. So my objectives will be to review some recent trial data supporting intensification therapy beyond just androgen deprivation treatment. So when I talk about intensification, it's anything beyond an LHRH analog, antagonist, or surgical orchidectomy. I will also review with you an algorithm that our national group of urologists, medical oncologists, and radiation oncologists have developed and we have published, and then review some of the non-metastatic CRPC trial data and thoughts on managing those patients, including the important question of sequencing and what do we do when people transit through different disease states. And then I will again share with you one of my patients. Again, my disclosures. I believe we're all familiar with the prostate cancer disease state model, and I apologize for the slides taking over and covering up some of the logo of your conference. But the disease state model speaks to patients transiting through prostate cancer from very localized disease at the beginning all the way through to multi-line metastatic CRPC. And the patient population of castrate-sensitive or hormone-naive prostate cancer is this patient population at the top. And one can develop that disease state either as an original diagnosis, where the first time a man is told about prostate cancer, he already has metastatic disease and has not yet been on any kind of therapy. Or it could be a patient who has localized disease, who maybe receives therapy for that, be it treatment with surgery or radiation, subsequently has a progression event. Usually those progression events are PSA only, but some patients failure at the same time. So you can become metastatic either as an original diagnosis or as a progression event after prior local treatment. And that's the difference between what we would call de novo metastatic disease or recurrent. And that's an important consideration because some of the clinical trials excluded patients with one or the other of those disease states. There's been a significant development of trial data in this space. If we go back to 2013, the original trial of the ASU-ICOC study by the French was a 9-cycle docetaxel study. The patients were a little bit better risk than were charted, and overall that particular study was negative. But then in 2015, we saw the pivotal charted clinical trial of docetaxel versus placebo for 6 cycles and an overall survival benefit. And we also saw that there was the STAMPEDE trial out of Europe, where a very heterogeneous patient population from locally advanced disease all the way through to metastatic disease. And they also showed an improvement in survival with docetaxel. And these hazard ratios are very similar to each other at around a 25% risk reduction for death by the use of docetaxel. Now, along the lines of follow-up thereafter, we saw data for abiraterone acetate. And the STAMPEDE and LATITUDE trial are the trials that really established those that drug on the market for this space. LATITUDE was a dedicated randomized phase 3 of only high-risk patients, and we'll walk through that definition in a moment. And again, the STAMPEDE study was a very heterogeneous patient population, but once again, you see a survival benefit with a hazard ratio that's a little bit lower at about 0.61 to 66. And therefore, up until 2017, the intensification therapy that we had was chemotherapy with docetaxel or abiraterone. And then last year, we had a number of clinical trials presented, which supported the use of enzalutamide or apalutamide. With enzalutamide, we had the ARCHES and the ENZAMET clinical trial, and those were trials that supported the use of enzalutamide either through trial data with a radiologic PFS endpoint or an overall survival endpoint. And we also had apalutamide with a survival endpoint. So we have a bunch of different drugs that are available. And I think the important thing about the 2019 data is that all of those trials were very broad in their inclusion criteria for the patient. It was all comers in terms of risk of disease, volume of disease, and recurrent versus de novo, which means that the trial data is very generalizable as opposed to some of the restrictions that we see with the docetaxel and the abiraterone data. It is important to remember then that we have these differing definitions of what these patients may look like based upon the clinical trials. And they're not the same, they're not interchangeable. When one looks at the Latitude clinical trial, they developed their own definition of risk eligible for the study. And a high-risk patient was defined as having 2 of the 3 risk factors that are listed here, being high grade, more than 3 bone lesions, or the presence of visceral disease. You had to have 2 of those 3 factors to be considered high risk, and you must be high risk in order to qualify for Latitude. So 100% of the patients on that trial met that definition. The Charted trial looked at volume. Now, they accepted all patients, but they did stratify by the volume of disease. And their definition of volume was the presence of visceral disease, 4 or more bone lesions, with at least one of them being beyond the vertebral body or the pelvis. And in their trial, it was about a 2/3 to 1/3 ratio of high volume to low volume. And when you look at these trials then, and you look at the patients that benefit from things, if you look at the docetaxel data, Charted and Stampede being your trials to support docetaxel, look at Charted, the overall hazard ratio is significant, but it's really driven by the high volume patient. And on subgroup analyses on further follow-up, our low volume patients really didn't seem to benefit from the chemotherapy, which led to clinicians not recommending chemotherapy for people with low volume disease. The Stampede study, because it was a very heterogeneous patient population, didn't necessarily look at volume or risk of disease. It simply stated that these patients benefited overall. And they have done post hoc analyses that would suggest that the amount of benefit is proportional to the amount of disease. And the high volume or high risk patient gets more benefit from the chemo. But they did present a nice post hoc analysis at ESMO a couple of years ago that would suggest that even a low volume patient could benefit from chemotherapy if that was the only drug option that they had. With regards to abiraterone, the Latitude clinical trial was all de novo metastatic patients. It was not patients recurring after prior local intervention. And it was all high risk, which means that you can't take a patient with low risk disease and extrapolate that they would benefit from abiraterone. And subsequently to that, the Stampede study also showed benefit for abiraterone, but similarly across the spectrum of all patients. And if they were lower volume or lower risk, then they got less benefit. So the takeaway message here is that chemotherapy really only benefited high volume patients, and abiraterone only really benefited high risk patients. And there's a lot of people who don't meet those criteria. So as I mentioned, docetaxel is restricted to high volume in terms of the amount of survival benefit, and Latitude was the de novo metastatic patient who were high risk by their definition. And with Stampede, it's sort of a supporting actor to both of these trials because it's so broad. But the Stampede trial on its own is really not able to tell you anything about volume or risk, and everything that they do to talk about that is post hoc analyses after the fact. So the question that has come up, and this was elegantly presented at ESMO in 2018, was whether or not risk and volume are the same. And in fact, they're not. Almost 20% of individuals could possibly be of low volume but high risk, or the other way around. And that's important because it does mean that we need to think about each individual patient in terms of his volume and his risk. And I would like to highlight this particular patient population who is both low volume and low risk, because that would be a patient population for whom would get very little, if any, benefit out of either docetaxel or abiraterone, and for whom none of these clinical trials are really applicable because they weren't inclusive of those patients necessarily. So the question you might ask is, well, does it matter? Is that a lot of people that we're talking about? And again, up until very recently, if you look at a patient who's low volume and low risk, I think that these would be very common patients. At least they are in my practice. You could have a man who's Gleason 3-4. He has 2 bone metastases and pelvic lymph nodes, but no visceral disease. that patient is low volume by charted, unlikely to get much benefit of chemo, and he's low risk by latitude. So technically, he didn't even qualify to go on the study, so you couldn't comment on the benefit that he would get from abiraterone. That represents about 1/3 of the patients in our practices. At least from the STAMPEDE analysis, that was 1/3 of the patients. So there's a large group of men for whom there was an unmet need if all you had available to you was abiraterone and docetaxel. And then if you add on to that, people who might otherwise get chemotherapy or abiraterone, there could be contraindications to why you would want to do that. Some people have medical contraindications to chemotherapy, and we couldn't give docetaxel if you have bad neuropathy. Maybe there's a reason why you don't want to use concomitant steroids, like a brittle diabetic. And monitoring of patients is challenging. In my country, the geographic diversity is huge. And I have patients who live 1,000 kilometers away from me who don't have ready access to laboratory monitoring. So if you have to put them on abiraterone and do liver functions and potassium monitoring, it can be a challenge. And of course, COVID-19 has changed everything about the way that we work. And it would not be desirable to use chemotherapy if I can avoid it, because I don't want the patient to have to be at risk of presenting to the acute care healthcare system. So therefore, when we actually had data that came out in 2019 for apalutamide and enzalutamide, it allowed more options, and it also allowed to broaden the patients who could theoretically benefit from treatment. In the TITAN trial, which I'll show you some data for in a moment, it was an improvement in overall survival by using apalutamide compared to placebo in an all-comer population of any risk or volume and de novo or recurrent disease. And that hazard ratio is very consistent with the hazard ratio that we saw in other abiraterone data. Enzalutamide, there are 2 trials that support this. The ARCHES clinical trial, which has a primary endpoint of radiologic progression-free survival, and the ENZAMET study, which was an overall survival primary endpoint. ARCHES is a randomized, blinded, placebo-controlled study, so that was the registrational study for the health authorities, whereas ENZAMET was an open-label study with a control arm of the non-steroidal anti-androgen of choice of the clinician. So it's more considered to be a supporting study for the approval of enzalutamide, although from a clinician perspective, I'm biased because I was an investigator. I think it's a more important study because it actually has a survival endpoint. If you like the graphics of a Kaplan-Meier plot, here you can see the TITAN trial with apalutamide, and this is our radiologic PFS endpoint. Again, this is a 2-year landmark analysis, and you can see at the 2-year landmark, you've got a 20% improvement in maintaining stable imaging. So your patient is less likely to have radiologic progression, and if they're not radiologically progressing, then hopefully they remain symptom controlled. The overall survival endpoint, this is an immature endpoint at this point in time, so a median has not been achieved on either arm. But again, at that 2-year landmark analysis, you'll see approximately an 8% improvement in overall survival for the use of apalutamide. What's important to remember about this, and I'll touch on it in a moment as well, is that some patients on the TITAN clinical trial did receive chemotherapy before they randomized to either the placebo or the apalutamide, but it was only about 10 to 15% of patients, and all the chemotherapy was done first, and then the patient randomized. So this study is unable to answer the question of triplet therapy versus doublet. It really just answered the question of apalutamide versus placebo. The ENZAMET trial was an intergroup study led by the Australians, and it was an open label study, and the control arm was the anti-androgen of choice, and most patients received bicalutamide in the control arm. Similarly, we do not have median overall survivals, but we do have a landmark analysis, but at 3 years rather than 2 years. And the control arm is improving or is inferior to the enzalutamide arm, with about an absolute difference of 8% in overall survival. Once again, you see about an 8% improvement in your patient being alive, but this trial has 1 year more of median follow-up compared to TITAN. One of the important subgroup analyses that comes out of ENZAMET is the concurrent use of chemotherapy. One of the unique features of ENZAMET was that the clinician could choose whether they wanted to give docetaxel to the patient. And if they did, it was concurrent, which is different than Titan or Arches, where the chemotherapy was sequential. So on ENZAMET, if I chose to give a patient chemotherapy because they were high volume, then what happened is their chemotherapy and their randomization occurred at the same point, and then they continued to receive their enzalutamide while they received their chemotherapy. And what we learned from this is that if a patient was receiving docetaxel, there was no extra benefit from the addition of chemotherapy. But if the patient did not receive chemotherapy, then the enzalutamide makes a difference. So the take-home message is triplet therapy by giving chemo plus enzalutamide is not better than giving one or the other. And so then it becomes clinician and patient choice whether you might choose to give chemo or an oral agent like enzalutamide. And it's more toxic. There was more febrile neutropenia and more neuropathy when you combined chemotherapy with enzalutamide. So we should not be doing that type of triplet therapy as concomitant treatment. I apologize, the formatting, the lines disappeared on my graph here, but for the Arches study, this is again an enzalutamide placebo-controlled study. There was a significant improvement in radiologic PFS of about an extra 18 to 24 months with an overall survival endpoint that was immature. So again, caveats, what do you need to take away? Well, first of all, with Arches and Titan and the issue of docetaxel, the clinician could choose to give the chemotherapy, but in those trials, it was sequential. Chemo first, then the randomization. And only about 10 to 20% of patients were managed that way in the context of either of those trials. And the subgroups are so small that you can't really gain any information about triplet therapy versus doublet. So right now, I don't believe that there is a role for sequential therapy here. I think that as a clinician, we choose either docetaxel or an ARAT, and we stick with it, but we don't do triplet therapy. In the ENZAMET study, the concurrent use of chemo with enzalutamide didn't add anything, and it was more toxic. So we definitely don't want to give chemotherapy at the same time as enzalutamide. And once again, I think you pick, do you want to give chemo or do you want to give an oral agent? So based on that, our National Canadian Neurology Association group, in conjunction with the Uro-Oncology Group of Canada, has come up with guidelines. And the guidelines for docetaxel would be suggested that it would be a high volume patient who would get the benefit. The low volume patient is only listed here as a possibility because of the subgroup analysis within STAMPEDE. Similarly, for abipred, they've written it as high volume, but they are extrapolating, and I believe incorrectly so, that this is really high risk as per the Latitude clinical trials. So that's why it's important to look at both volume and risk. The important thing about apalutamide and enzalutamide is that because of Titan, ENZAMET, and Arches covering all patient populations, there is levels of evidence that are strong to use that for individuals of any risk and any volume. So as such, what are your sequencing options? How do you treat people when they transition from castrate sensitive to castrate resistant metastatic disease? If an individual is currently just receiving ADT because perhaps he's been on ADT for a while and never had a chance to be intensified, you can effectively do whatever you like when he becomes a CRPC patient. Many people will receive an AR targeted therapy. I would say that that would be far more likely than first-line docetaxel. We do not use sipuleucel T in Canada. It's not approved here. It's really a US agent. And radium-223 can certainly be an option for patients with bone-only disease or very small lymph node disease. But again, as per how that drug was approved, it really should be for chemo-ineligible or post-docetaxel patients. Now, if I've intensified with chemo like a charted protocol, then when they become castrate resistant, most patients will receive an AR targeted therapy followed by cabazitaxel. But this would arguably be 98% of my patients today receive an AR targeted therapy as their intensification. And when they become castrate resistant, most patients are going to receive docetaxel. We know in the metastatic CRPC setting that back-to-back ARAT doesn't really work, and there's nothing biologically plausible that would make it any better when they transition from hormone sensitive to castrate resistant to use ENZA followed by ABI or ABI followed by ENZA. So as such, we're almost at a position now where first-line CRPC therapy has come back to docetaxel, just like it did back in 2005 when the TAX-327 and SWOG 9916 trials came out. What's on the horizon to watch for? The PEACE 1 study will give us some further information about the role of triplet therapy with abiraterone and ADT plus RT. Right now, we extrapolate from the STAMPEDE study about the role of RT to the prostate and low volume patients, but we're also layering on drug therapy on top of that, but we really don't know if that triplet therapy is better than doublet. And then I think most of us are really interested in looking for the AirSense study, which will look at darolutamide, which many people feel is a more tolerable ARAT. And this will be a study that will really examine triplet therapy versus doublet, because all patients on this study receive chemotherapy and the randomization is between darolutamide or placebo. What this study will not answer is whether monotherapy with darolutamide would be an intensification strategy that we could use. Now, very briefly to finish, I'll just mention non-metastatic CRPC. The principle is the same, that we're taking drugs that work in the castrate-resistant space and removing them earlier. And initially, we knew that these agents gave us a metastasis-free survival benefit, but now we see overall survival. And it doesn't matter whether you pick the apalutamide trial, the enzalutamide trial, or the darolutamide study. They all have differing follow-up lengths, darolutamide being the least mature and apalutamide being the most mature. But they're all basically telling us a same story about a 2-year improvement in metastasis-free survival and about a 1 to 1.5 year improvement in overall survival. The problem is this is a vanishing space of patients. These are non-metastatic patients with high-risk disease based on a short doubling time, but by conventional imaging, they're non-metastatic. And as the world starts to get more experience and access to novel imaging with PSMA PET, for example, we're going to find that most of these patients are actually metastatic. And in fact, if you look at a real world population, there was a presentation at the AUA. If you look at a Spartan-like population in the real world and you subject them all to PSMA imaging, about 98% are metastatic. The question is going to be whether or not we're going to treat them like a metastatic CRPC or a non-metastatic. If you're giving a drug like enzalutamide, it doesn't matter because it works in both settings and it's approved in both settings. But apalutamide, for example, is not approved in the metastatic CRPC setting, so it would make a difference in terms of drug access. I would also caution about reading too much into the Spartan trial where they gave open label abiraterone upon progression. It was really done more as a practical way to get people on the study, but there's no data on efficacy of giving abiraterone after apalutamide. And in the metastatic space, we know that back-to-back ARAT doesn't work very well. And so I feel that probably most of these patients are going to require docetaxel. So a quick conclusion, and then I'll share my patient with you. All patients now, irrespective of volume or disease risk, or whether they're de novo or recurrent, can benefit from some intensification therapy. And if you choose not to intensify, it may be because of patient preference or extreme comorbidity or age. I believe that an ARAT is pretty much what we're almost all going to be using, unless there are cost containment reasons why one might want to give chemotherapy because docetaxel is quite inexpensive. But if I was thinking about the patient where I might be pushed to use a charted type of protocol, I might think of a younger patient with a high Gleason score and a low PSA, especially if there's visceral disease, because that's the kind of patient that probably has a disease that's not as driven by the androgen receptor and might get more benefit from a cytotoxic like docetaxel rather than a drug like APA or ENZA or abiraterone. And then as we change disease states, whether we're migrating from castrate-sensitive metastatic to castrate-resistant, or we're migrating from non-metastatic to metastatic CRPC, I think we have to reintroduce chemotherapy early because back-to-back ARATs are really not going to be beneficial. So I'll quickly close with a patient case. This is a patient who 5 years ago was 67. He was followed by his primary care physician with screening PSAs. And unfortunately, when his PSA was 12.8, he was lost to follow-up for 6 months. When he finally resurfaced, the PSA was repeated and it was up to 36.7. That prompted a biopsy of Gleason 5-5 disease and a staging investigation that showed pelvic lymphadenopathy and a sternal metastasis. The disease was lytic in the sternum on plain imaging, and there's a lytic defect in the manubrium, and you can see a periosteal reaction around it on his bone imaging. He's considered to be low volume by the Chartered criteria because he doesn't have visceral disease and he has a solitary bone met. He's also considered to be low risk by Latitude criteria because his only feature is his Gleason score. So he's one of those 37% that doesn't really qualify for abiraterone and doesn't really qualify for docetaxel. So we enrolled him on the Enzamet clinical trial and he randomized to enzalutamide. And within 3 months, his PSA was undetectable, his sternal pain went away, and it was quite swollen with a defect on his chest wall, and that disappeared. He was well for 3.5 years, and then he started to develop a rising PSA and more pain, and now his bone scan shows multifocal bone disease, and his PSA is in the 50s. So I've started him on docetaxel prednisone, gave him 10 cycles, his PSA nadired at 1.2, and his pain disappeared. Shortly after completing his docetaxel, he once again had a rising PSA and also, more importantly, a recurrence of his pain. So the clinical symptom for me is more important than just the number of the PSA. And I started him on cabazitaxel, but at 20 milligrams per meter squared based upon Proselica data that says 20 and 25 give you similar outcomes and it's less toxic. And after 6 cycles of cabazitaxel, his pain resolved and his PSA is 4. He's currently being observed. I have tumor profiled him, but unfortunately he doesn't have a mismatch repair, so he won't qualify for drugs like olaparib. So if he progresses, unless there's a clinical trial, I might try the cabazitaxel again or possibly radium, although we have some restrictions on funding with radium. So in summary, castrate-sensitive disease really benefits beyond ADT, and our overall survival in these patients is dramatically better than many years ago. Upon progression, from a CSPC to a CRPC, I think you're looking at a docetaxel cytotoxic followed by cabazitaxel. Radium can always be considered for bone disease, and we should not be afraid to use it sooner than later. It's not considered a last resort treatment, and I think if we wait too long, then you're not going to get any benefit. And again, non-metastatic CRPC is really a vanishing entity with new imaging, and we're going to have to figure out how to interpret our new data in light of the fact that we are going to be doing a lot more functional imaging with PSMA. So with that, I will stop and gladly take any questions.